What's going on, everybody? We're going to talk about the thoracic spine today. So considering the thoracic spine, it's a really important linchpin to basically anything that happens above the waist. If we go back to our joint by joint approach and looking at the joint by joint approach, the thoracic spine kind of sits between three pretty vulnerable parts of the body. So we've got the lumbar spine below, where we end up having a lot of stability issues. We've got the cervical spine above, where we end up having a lot of stability issues. And then we've got the glenohumeral joint in the shoulder, where we again end up having a lot of stability issues. Now, the thoracic spine, as this linchpin between, is very often missing in mobility. And when it's missing in mobility, a lot of stresses that go through the body, instead of being absorbed, they are going to get absorbed in these areas that can't control it quite as well. So again, in that joint by joint approach, it's probably a mobility issue that we're seeing in the thoracic spine. When we look at the thoracic spine of the components we may be missing, it's usually going to be some component of extension and rotation. And if you go back to your anatomy and biomechanics studies, in the thoracic spine, from a joint perspective, from a functional perspective, extension and rotation are really coupled motions. So it's an important component here when we go to look through our assessment, is that if we measure rotation, we can still get an idea of what's happening from an extension perspective. So really, rotation on one side is just more aggressive extension unilaterally on that one side. So as we go through our assessment, we're going to really look for, and especially our top tier assessment, we're going to really look for the contribution of extension and rotation from the thoracic spine in some motions that are going to happen at other parts of the body here. Okay, so let's start with Aaron here, and we'll start in our assessment looking at some top tier components of the SFMA. So I'm going to have you go side view this way. So we'll start with extension. So we'll start with a hands overhead multi-segmental extension. And when we look through multi-segmental extension here, all you're trying to look for, that's good. We're trying to look to see, there's no measurement to take, and you look at all your same components of multi-segmental extension. We just want to have in the back of our mind how much the thoracic spine contributes to that. And sometimes, loose fitting clothing is going to be difficult for you to see. Sometimes it just means you got to pull their shirt up. We do one more time for me here, Aaron. Good. So you can see he gets pretty good global contribution of extension from all parts of his spine there. In some folks, you'll sometimes see a hinge point lower down. Yep, exactly like that. Very stiff thoracic spine, not really contributing to the motion. And again, I mean, that's not fair to say. We don't really know it's stiff yet. We'll have to go through our assessment to figure out maybe why they can't get to that point. All right, so that's a piece of that puzzle there. In that same position, so even before we get to multi-segmental extension, we could just have him globally raise his hands up over his head. And again, looking here now at flexion of the glenohumeral joint, are we getting a contribution of extension from the thoracic spine? Sometimes that doesn't happen. Can you show us what happens when that doesn't happen? So we've got a kyphotic thoracic spine. There's really nowhere to go now, right? Again, back to thinking about the function of the thoracic spine now in the upper extremity is the thoracic spine's got to get out of the way. So by getting out of the way, it's going to go into extension so you can clear so that your shoulder blades can actually move around your ribs, protract around your ribs to allow the shoulder to go into flexion. When you're stuck in kyphosis, stuck in flexion, that can't happen. So we're looking for global extension there. You can look at this all unilaterally too, but generally a bilateral assessment on overhead flexion is going to be a great way to get a good look at the thoracic spine. So let's go facing the camera now here. So now we can look at multi-segmental rotation. So we'll have him rotate to his right. Now when somebody rotates to the right, there's a few things that are going to happen. So he's going to get a hip contribution here, right? So you see his hips rotate to the right. So what I'm now looking for is he getting a separation from his hip line to his shoulder line? Good. And then do one more time there. So I've got a line coming from his left hip to his right hip, and a line coming from his left shoulder to his right shoulder, and I want to see a separation there, and I want to be able to see contribution from the middle part of his back, from his thoracic spine when we do that. Let's go the other side. Right, so again, hips give a contribution, and then do we have a separation of that hip and shoulder component? All right, so now will you face that way again for me? So again, we said thoracic spine, linchpin for everything above the waist. So we looked at multi-segmental extension, which might give us a good idea of something going on in the low back and the contribution of the thoracic spine. We looked at overhead reaching with the upper extremity, again, another one of those vulnerable places. We may also want to consider something going on in the cervical spine. So in the cervical spine, the contribution, or what we're looking at, is really more the upper portion of the thoracic spine. And so we'll start with extension here, so looking up at the ceiling. So that's very good global extension. You can even see his upper thoracic spine contributing to that. Come back and show me a hinge. So this is extension where the thoracic spine isn't playing a role. Everything's happening above C7 here, right? And so that would be a good tool to pick out, or something to pick out quickly to say, maybe we need to address or at least further assess the upper portion of the thoracic spine. So vulnerable components. We could dive a little bit deeper and look at combined motions here. So let's turn this way. So we could look at combined motions here. So we could have him go underneath. Good, so underneath here, what you're really looking for, trying to appreciate is, he's got a little bit of it, the element of scapular winging here. So how much does his scapula come off of his rib cage? And that could be a good idea of maybe his overall position of his thoracic spine and its contribution there. So if he's in kyphosis here like this, yep, exactly, then you can see the shoulder blade really flips up because it's got nowhere to go, right? So if you imagine the ribs poking out, the shoulder blade is just going to wing out this way. So if they're stuck in kyphosis like this, you're going to be able to jam your fingers underneath the shoulder blade. We can also then look at combined motions into flexion, abduction, external rotation. And same thing now, this is unilateral. We want to see a little bit of extension, or at least an initiation of extension, and a place for the shoulder blade to, like a pocket for the shoulder blade to sit in here really nicely. All right, so then moving to the table, we want to break down a little bit more specifically what's going on with the thoracic spine. So important piece to consider here, in order to do that, if we're going to look at thoracic spine, the best way we're going to be able to measure that is looking at rotation. Measuring extension is going to get difficult, but measuring rotation we can definitely do. And remember, we already said that the extension and rotation are coupled motions. So if I can measure rotation, I can get a very good idea of somebody's capability. But super important, in order to do that, we need to be able to lock out the lumbar spine. So we don't want the lumbar spine to contribute to this motion as much as possible. So the best way to do that is put somebody in as much hip flexion as we can. So we'll have him rock back in a child's pose here. So now his lumbar spine is effectively flexed forward and locked out. When the lumbar spine gets flexed forward by this forced hip flexion, the lumbar spine vertebrae get in a point where they really have no ability to rotate. So our rotation is basically going to happen from here up. So then in order to lock this out even further, I'm going to have him hunker down and put his elbows in between his knees. Now this is where we've got some kind of freedom here. We can do some different things. So the gold standard and the best way that I like to look at this, especially if we're looking at the upper extremity, is to have him put his hand behind his head. So when his hand goes behind his head, this then looks like the combined motions we did in standing there. And then I'm going to ask him to rotate around and look up at the ceiling. Good, Aaron does a great job here. Come back down. So if we're looking at the horizon, so we're looking from head on here, we can just get an appreciation and say that, does he get past, so if the horizon is here, does he clear 45 degrees? The answer is absolutely yes. And by 45 degrees, I mean from left shoulder to right shoulder. So this being an imaginary line coming up like this. So the answer is yes, Aaron clears it. And that's probably pretty good for most of the general population. When we start talking about our overhead athletes, so anybody that throws or swims, or even think like Olympic lifters, CrossFitters, people doing things overhead regularly, we probably want to see that number get much closer to 60. Now, measuring 60 just there, looking globally, is very hard using your oculometers. A better version of that is to take your cell phone, and if you, whatever kind of phone you have, just an inclinometer. If it's an iPhone, there's the Measure app. If not, just get an inclinometer and you've got this little level. We can then put this on the spine, and so I'll go at the inferior angle of the scapula, so it should be around T7, so kind of middle range, and have him do the same thing. He's going to rotate up, and this will give us a number, and Aaron's at 59, so he's not quite an overhead athlete. We're close. Okay, so that's a great way to measure that. Let's look at the other side here just for fun. Great, Aaron's 62 left side. Great, looks very good. So that's combined motions in that way from a flexion, abduction, external rotation piece. Remember, we said the function of the thoracic spine in rotation there and in extension is really to get out of the way so the shoulder blade's got a nice pocket to go into. That's a great sign that we can get to that point if we're getting closer to 60 degrees. Not everybody can get to that position though, and maybe we still want to look at the thoracic spine in this kind of gold standard assessment position. So we can make some modifications. We can go hand behind back. So hand behind back, same thing. We still get the same line. We're still looking for the same line. We could also go hand across chest, so to opposite shoulder. And then same thing. So any modifications we might have to make for the upper extremity there, we can do. Now, from an assessment standpoint, this again, gold standard position, but this position we could replicate. So not everybody can get here. Maybe somebody's got a knee flexion issue, or they can't kneel on their knees, or some old folks can't get to this position. Some immobile people might have a hard time. So another place we can go here is, let's have you lay on your left side. So he's laying on his left side here, and we're going to have him tuck his knees up. So we want to replicate that hip flexion position, again, to lock out this lumbar spine as best we can. So we can get him here, knees tucked way up as much as we can. I can then hold him down, or I can have him take his bottom hand and hold this down. We then have the same arm consideration. So we can go hand behind head, we can go hand behind back, we can go hand across chest. Behind head, best version if we can, so let's go there. So here, as he rotates over, we can get a feel for how close he gets to the table. So from a measurement perspective, I'm going to reach over top of you here, we can look fingers to floor. So I can go finger widths to floor, how far does he get? And that can be my measurement. You could really pull out a measuring tape if you want, but this is a good kind of quick and dirty screen to get that done. Finger to floor measurement from shoulder blade to floor. Okay? Yep, we can do the same thing hand behind back. You can do the same thing hand across chest. But again, the biggest mistake I see here is when people measure or even use this as a tool to work, is their knees are either at 90, which is not going to be enough, or they're below 90. And so when he goes to rotate here, you can see that there's a lot happening here at the lumbar spine. So we really haven't effectively locked out the thoracic spine. This is a really common problem we see with this as an assessment or as an intervention tool. So other ways that we can modify this from an assessment perspective is we can bring knee up this high. So if you find that getting fingers to floor over there, they pass that and they get there easily, is if we take the bottom leg out, now we effectively put him in a little more rotation this direction. So you can see there's a little slant angle on his pelvis. So there's a little bit more components for us to consider, a little bit more motion he'd have to clear to get to the side. So again, this having to be up past 90 degrees. So now let's sit up for me here facing this camera. So another way that we can modify this, I'm gonna scoot back for me. So get him all the way seated here. And then we'll take a ball, we'll put it between his knees. So him having to squeeze the ball between his knees, if we've got something to support his feet, that generally helps quite a bit. Another thing we could do to replicate the position is we could get something to elevate his feet. So you can get him in a little bit more hip flexion. So if you put a stool, anything not on wheels, anything sturdy that could elevate, we can get a little bit more past hip flexion. But even for some people, that's a tough position to get to. So this is kind of a modification for folks that maybe have a hard time getting up and down from the ground. But forcing a squeeze here is just going to require a little bit of stability around the pelvis. Then we can go hands across chest and have him rotate. And then now I'm looking at this angle here. So I'm looking down, bird's eye view. How much rotation is he getting, again, from shoulder to shoulder? Let's come back this direction. So then another way we could do this is you could take a PVC pipe and put it on their back, have him up here in almost like a back squat position with his hands. So again, for somebody that maybe can't quite get to some of these other tough positions, but we could still get to a spot that requires a little bit of abduction, a little bit of external rotation, again, looking for that pocket for the shoulder blade to go into. So those are some modifications from a testing perspective. Okay, so we've talked about rotation assessments. We do maybe want to get an appreciation for extension here too. And so extension can be a tough one to find, particularly passively. We've seen it actively, but passively extension can be a tough one to find. But I find this to be a pretty good way for you to get a feel for how much passive extension somebody can get into. So I'll have Aaron go hands behind neck here like this and let his elbows drive forward, kind of right at the camera there. And then this turns into kind of a handle for me. So my front arm goes here, and then I want him to give his weight to me. So I've got to hold him up here. So I'll generally put him a little bit forward into flexion. So then I've got a good grip on him here. And then I'll take this grip with my finger, where my thumb and my index finger make a little V. And then I just put that straight on the thoracic vertebrae on the back side there. And I'll use that as a hinge to get a good idea for extension. Now we don't have to go through and segmentally test each vertebrae, because we know that that's not really where the issue is going to be, and that we know that there's much more global motion happening here. And even if I put my fingers in one spot, we know that that's not the only segment that's moving. So if I usually get an upper, a couple somewhere around above and below T7, and then one more global extension a little bit more distally there. Okay, let's lay on your stomach here now. Okay, so now in prone, we can get a picture, we can get a feel for some more things. So we've seen a bunch of movement components, some active, some passive, but now we can just appreciate the structure a little bit. So we can get a look at musculature here, and sometimes you'll see tone or size differences on both sides, paraspinals running down both sides, and in overhead athletes, and especially very one-side dominant people, you'll often see an increase in musculature on their dominant arm side, and that could be a normal variant relatively. So first thing you want to do here, just from a palpation perspective, sorry about the cold hands, is you want to do your overall tone assessment. So We get an appreciation for muscle tone, kind of all the way up and down the thoracic spine, maybe just to get a feel for the soft tissue restrictions here. Remember, soft tissue restrictions is probably going to be the biggest thing that's going to limit our motion and our available motion in the thoracic spine. So we do a tone assessment, so we get a feel for the amount of tone through the thoracic spine. Aaron's got a little bit of tone down here. That's a little bit of a tender spot, yes? Okay, and we do a tone assessment, kind of working up this side too, so we get an appreciation side to side on things here. Your tone assessment can lead right into some kind of tone change. So from the tone assessment, if we found a little area of higher tone that may be restricting some motion, we could go right in with one of our tools. So we could take our blades or we could take our hands, and then from a perspective of changing tone, remember it's all about deep pressure. So if we've got a high tone area and we want to make it lower tone, we want to get the tissue to relax, it's all about deep pressure. So deep pressure can be done with your hand. Hold until you kind of feel it relax. I got this question from a PT student the other day. He said, cool, yeah, so how long do I do that? How long do I hold pressure? And I said, I really don't know until it relaxes is the answer. As soon as the tissue relaxes, you're good to go. So you should be able to feel that happen underneath your hand or underneath the tool. But slow, deep pressure to get this spot to relax. Now, the other thing you want to consider here as you've found this area of higher tone is then you go back in your mind to some of the assessment pieces you were looking at before. And in Aaron, was there a point where maybe something was a little bit different? So the one thing I would say, of everything he did, Aaron moves very well. He's a tremendous athlete, as he would tell you. He'd be the first to tell you. But when we were looking at passive extension here, Aaron was a little bit limited in this more lower part of his lumbar spine. So the one closer to T11, T12 that we looked at passive extension, he was a little bit limited. And that's kind of right where we're finding this little increase in tone. So then again, we go here with our tools, deep pressure. Hands or cups even would work nicely here. So we could use a suction cup as a way to change the tone in tissue. And so we go right to the tissue of high tone and lay the cups on. You can leave it static, or if you put a little bit of emollient on there, you could drag this around. But again, all trying to hit these deeper layers of tissue with this kind of slow, sustained stress to allow for relaxation in the tissue there. Once we get relaxation in the tissue, then we could move on to our next version of reprogramming and kind of getting the tissue moving again. But we've got one more thing to look at from an assessment standpoint. The last piece to consider here is you go back to your schooling, and really what you want to look at is the joint. So the joint's probably the least piece that would contribute to a motion restriction, but still a very important piece of the puzzle. But we can get an appreciation for how well the joints move here. And so I'll look at, again, we said, one segment is probably not the end of the story, and we can look a little more globally here. So I'll use a skin locking technique where you go the pisiform portion of both hands and we lock the skin down. So I'll drag the side away from me, I'll drag caudally, and the side towards me, I'll drag towards the head. So we create this kind of skin lock, and then I'll just look at the ability of the thoracic spine to tolerate a little bit of PA pressure. So a little bit of pressure pushing from posterior to anterior. And I'll look at a few different levels, kind of working our way up here. And then you're just trying to get a feel for some appreciable difference in one spot or another, an area that might feel a little bit more stuck. And then again, like with the tone, your assessment can turn right into the treatment. So in this spot here, we can turn right into adding some PA pressures. You can do that in your different grades of mobilizations. This could turn into a grade 5 mobilization, so a quick thrust. So you have Aaron take a big breath in and then out, and then give him a quick thrust there to make the change. Again, that's a fast change. There is some kind of transient change that happens, but all that only matters if we do something to reprogram it. All right, so now moving into some of the drills that we can use and things that we can do to help kind of reprogram and reset the system. With Aaron, again, now we're talking about moving the thoracic spine. We need the knees to tuck up past the hips. So this is a good table version of things. So we'll get the knees up past the hips. I can have him hold that down, and then we'll go hand behind head here. I'll often sit and kind of block their hips here. And then I can put my hand here, or they can hold it down. And then he'll open up this direction. I can add gentle overpressure this way. So we can add a little overpressure into the stretch and then have him come back and then open up again. We can consider breathing with here. Again, remember all of the ribs attached to the thoracic spine. So breathing is a super important component of this. So if you think mechanically, Inhalation, so breathing in, should expand the thoracic cage and actually allow for a little bit more rotation. So inhalation should assist rotation. And you can use it like that. You can use on rotation, use your breath in on rotation to allow for a little bit more opening. And I think that's great. One thing that I find actually works quite well is, let's come all the way back to the middle here, is I'll have him start with no breath. He'll open all the way up to end range, and then I'll have him do a full breath cycle here at the end, an in and an out. And then give him a little bit more overpressure. And I'll tell somebody when they go home, their objective is get themselves all the way to end range, do a full breath cycle, in and then out, and on the out, try to sink a little bit deeper. You can think a couple of things happening there, right? You can think mechanically at end range, you take the joint to end range, and then you really ask the ribs to do the mobilization for you, right? So you take them to end range, and then the full in and out toggle should give a small mobilization to the spine. But you also think of the sympathetic, parasympathetic component here of the autonomic nervous system, and that kind of relaxing exhalation at the end can allow for a little more vagal nerve drive, a little more parasympathetic drive, and a little bit more motion at the end. So kind of a neurological tone and probably a mechanical component as well. So full breath cycle at the end to kind of toggle the end range. And I'll use that in most of the drills that we'll go through here. So this is a good initial kind of hands-on way to get a little bit more push and start to get them a little bit more being an active participant in the treatment. Let's go quadruped here. So we can take them back to the gold standard where, again, the test can become the treatment. So we'll lock out the lumbar spine, have him go elbows between his knees. We're going to go left hand behind his head, and he's going to open up. And I can, again, add a little bit of overpressure here. So if I take right hand here kind of on right shoulder blade, left hand scoop around. Again, you got to be mindful of who you're working with, but left hand scoop around on the front side of the shoulder here. And you don't want to grab the actual humerus. You probably want to go a little more towards the pec so you can actually move his body here. And then you give him a little bit of overpressure into end range. And again, I'll have him take a full breath there at the end. Good. And then come back down. One more time, open up. Full breath at the end. Give him a little bit of overpressure there. Okay, good. All right, so working through some of our reprogramming techniques now, kind of moving away from the table, again, making them a little bit more of an active participant here. We'll work through a half kneeling thread the needle. So we'll use this half kneeling position, this kind of get up position. So he's 90-90 half kneeling as a way to lock out that lumbar spine again, keep the pelvis relatively stable. Because we're not in as much hip flexion as we were in some of the other positions, we'll start to get some contributions from other places, but that's really okay, right? Like after we've isolated the thoracic spine and we've really opened things up, we want to start to figure out how can we move them into more global motion? How can we encourage the thoracic spine to contribute to more global motions happening everywhere? So we're going to start to integrate a few things. So we'll do something called a thread the needle here. So his left arm's going to reach through and then come all the way back up towards the ceiling. And we can integrate a few things. So here at the top, we can do some more combined motions. So we can add a little bit of, encourage a little bit of supination, external rotation, shoulder pack down. Combined motions are things that we want to look for at the top here and then reaching back through. So have that turn into more internal rotation as he reaches through and pronation, and then external rotation and supination as he comes back up. Good. And let's show the other side. Great. Well, with this knee, something we want to consider is in a lot of people as they attempt to reach through and get more motion, this will all collapse. So we can give them some nice external feedback and stand this foam roller right here and say, you can't touch the foam roller. So now he's got to hold his pelvis a little bit more stable. And so that can be one way that we encourage a little bit more of this to kind of actively happen at the thoracic spine. So let's go hands and knees here now. It's on the other side. So we're gonna do another version of thread the needle. And this is gonna be relevant, particularly more with our upper extremity folks. But in the upper extremity, there's a few lines of tissue here that can really contribute to tissue issues. That does rhyme, you can lock that in, to tissue issues. So when we do this thread the needle, we'll use the foam roller to make this a little bit more passive. And we can do this in 3 different ways. So the foam roller angled straight away from him is going to be a great way for this. I'll throw muscle names out, but we're really talking about lines of tissue, but almost like rhomboid middle trap. If we found tissue issues there contributing around the thoracic spine, this is a good way to encourage some thoracic spine rotation, but also get kind of a passive mobilization of that tissue. All right, if we angle the foam roller up and out, now we can take this more kind of lat, teres, back of the cuff line, back of the rotator cuff line, and encourage a little bit more lengthening here as we go through a little bit of thoracic rotation. Let's angle down and back. Now in this position, we can, as he angles down and back and reaches back through, we can take this kind of upper trap levator line portion of things and get a little more mobilization through this tissue as we encourage a little thoracic rotation. So these are great drills for somebody to do. You could even come in and add a little overpressure on these if you like. Okay, perfect. Let's go 90-90 here. So those are kind of simpler drills. We'll move into some things a little bit more complicated here now. So we've said that tissue, we've said that joint, and we haven't quite talked about breathing yet, but we'll talk about breathing a little bit more in another video. But those are all things that can contribute to limitations here in the thoracic spine. This is a very nice drill that's going to wind up some of those bigger, longer lines of tissue through the trunk and the midsection and the hips that are going to contribute to some of your thoracic spine dysfunctions. So this 90-90 position will have him rotate over that front leg side. So he's going to rotate towards me, both hands to the ground. He's going to create as much rotation as he can through here. And then in this position, I'll almost always have them take 2 of those full breath cycles we talked about at the end. So we'll go 2 big breaths in, and we can really start to cue where the breath comes from. So especially for Aaron, we found that this was a big limiting spot for him. So I'll say, when you breathe, I want you to find your breath right through here. And you can give him a tactile cue with your hand as a way you want him to push his breath out. So he's really trying to force big expansion of the rib cage back and down here. So now we'll progress this. He'll drop down to his elbows, wind up those lines of tissue just a little bit more, and have him take 2 breath cycles here at the end. Perfect. Good. And then I'll have him take this right hand and have him reach through towards me. So he's going to reach through towards me here, and again, 2 breath cycles at the end. Again, you could add a little overpressure here if you like, or they can just kind of roll through this on their own. Good, and then slowly wind back out of that. I mean, this is a pretty wound up stretch, so this isn't something to pop right up from. You're gonna kind of slowly pull your way out of that position. Okay, let's go half kneeling here. Right knee up. We're only rotating to the right today. Okay, so we'll go hands behind head. So now again, we're in a pelvis kind of locked, relatively locked position. Half kneeling can help us relatively lock this. Again, kind of a higher level rotation drill here. So we're gonna combine rotation with lateral flexion here. So he'll go hands behind head. The first time people do this, there's kind of a balance component. So I'll usually come in and give them a little hand assist just to help, because balance isn't really what we're attempting to work on here. So we're going to ask for a little bit of lateral flexion. So I'm going to ask him to rotate down, rotate, and then bend down, and take 2 big breaths here at the end. And so I'll just have my hands on his elbows here as a little bit of an assist, at least the leaning elbow. After his 2 breaths, we'll undo the lateral flexion. He's going to grab a little more rotation and flex one more time. Give me a couple of breaths there at the end. Again, I just give him a tiny bit of support here. But this is really a drill that somebody can do independently. Come back up, give me one more rotate, 1 big breath, and then come back to the middle there. Good. So relatively quick ways to kind of more aggressively pry the thoracic spine open. Now, as we're talking about motion, we're talking about contributing some more things to it. So most of the things we've done have been relatively pelvis stable, less contributions from lower down. Let's start to look at how the thoracic spine can work with the upper extremity, with the cervical spine, and with the lumbar spine. So we'll go on your stomach, hands over your head. We're going to look at prone rolling, prone to supine rolling. So we're going to go left arm lead here, rolling that direction. So what we're looking at here is for global contribution of his spine. I'm going to have you pause here at the end. So see Aaron's neck, he's got rotation and extension in the cervical spine. His scapula has driven down and back, shoulder blade down and back, driving this kind of more Y angle here. Often a problem we'll see is people end up going T and then they're just cranking on their shoulder. To make this more of a Y, we're going to get more activation lower down. See his lumbar spine's contributing to this motion, and then he'll go all the way over to his back. Goal of this drill is to have, let's do one more, come back towards me. Goal of this drill is to have nothing happen from the waist down. So all of rotation initiating from above. So you want relaxed and quiet lower extremities. I'll often cue eyes to follow the hand as they're coming up and back. If eyes follow the hand, the cervical spine will kind of do the leading. The thoracic spine then just gets to practice or gets to be a component of rotation here. All right, now even more aggressive, let's go quadruped here. We'll go thoracic bridge. So a more aggressive version of things as we start to look at maybe now loading this pattern. So if we do this whole thing, what we've done is we've assessed, we've maybe reset the tissue or reset the joint or found a little bit more motion somehow. We've found some drills that maybe isolate the thoracic spine a little bit more and started to work through more active, Aaron's active control of the motion. Now we just looked at a more kind of global version of things, is how can the thoracic spine contribute to motion along with cervical, lumbar, and the upper extremity, right? So seeing how that linchpin we talked about can kind of contribute to global motion. We're going to start loading things now a little bit. So the last component of all of this is how do we now reload this and really make that change that we did meaningful. So we're going to do something called a thoracic bridge, which is going to require a lot of tension actually through his hips and through his upper extremity. So he's going to go quadruped, knees come off the ground, and right hand stays pinned to the ground, and he's going to sweep his right leg through, sweep all the way around, and bridge his hips up towards the ceiling. So now he's got tension through his hips, this reaching straight up. We're looking at this line right here, shoulder blade packed down. So he's got this incredible separation of hips and shoulders. So we were talking about that measurement angle before. Pelvis relatively on the horizon, shoulders basically almost 90 degrees flipped up and down. Come back down, show the other side. Beautiful. Locked in here, pelvis facing up towards the ceiling, tension through his glutes, tension through his lats, and packed down back of the shoulder. Separation of his shoulders and hips through his thoracic spine. Great. Good. Okay, so we add a little bit of load that way with some body weight. The next thing we can do is put him in a more open change that's connected to the ground, still kind of using the ground as a way to pry things open. Now let's give him a little more open chain requirement and control. So we'll get back to this half kneeling position. We're going to do what's called a chop and lift. Good. So he's got a weight in front. This could be anything, medicine ball, kettlebell, dumbbell, really doesn't matter. And so we'll work on chopping down to his downside. So again, pelvis forward, shoulders open, and then we'll reach up and over. Good. If somebody's still having difficulties or if you're in the early stages of this, you can go back to what I said about inhalation, adding a little bit more rotation. So we can breathe in on rotation to find a little bit more. But these diagonal chop and lift patterns, great for proximal stability and giving him some stability in this rotation moment. Good. Perfect. So if we kind of sum up everything that we went through here today, we said the thoracic spine is important because it is this kind of linchpin in the middle of everything happening above the waist, right? So we could have, nobody's going to come to you with a thoracic spine issue, but they'll come to you with low back pain, a shoulder issue, even something maybe more distal down the upper extremity, this can become relevant, or a cervical spine issue. And then your job is to figure out how does the thoracic spine contribute to that? And we detailed some assessments and you find the issue. How do we attack the tissue? Is there a down regulation component that needs to happen? Is there a joint restriction that we need to address? And then we go through resetting it using our manual therapy. And then we reprogram with some of these drills that we use here, make them a little bit more an active participant, kind of from the table to the floor. In some components where the thoracic spine is a little more isolated, where the pelvis is a little more stable. And then we look at something more global, like prone to supine rolling, where the thoracic spine is integrated with the shoulder, cervical spine, and lumbar spine all together to combine to one motion. And then we can reload and really make those changes meaningful with something like a thoracic bridge or a loaded chop and lift.